Hi, my name's David Veal, and I'm going to be talking to you today on medication for OCD and BDD. I'm a consultant psychiatrist, and I'm based at the South London Maudsley NHS Foundation Trust and at the Priory Hospital North London. And I'm also a visiting professor at King's College London. So, I'm going to be talking today about the rationale for prescribing SSRIs and clomipramine. I'm going to talk about the potential side effects and how they can be managed. I'll talk briefly about other drugs used in OCD and BDD, pharmacogenetic analyses, and very briefly transcranial magnetic stimulation for OCD. So the main drug of choice for OCD and BDD is this class of drugs called SSRIs, and that stands for selective serotonergic reuptake inhibitor. They're selective because they tend to go for just those particular receptors, the serotonergic receptors, and they work by inhibiting reuptake of the serotonin, and therefore they boost that particular pathway. And that pathway is mainly inhibitory, and therefore it tends to generally reduce anxiety. And although they are antidepressants, they're much better actually at reducing anxiety. And the research question in all the big trials is, does an SSRI on average do better than a placebo in this group of patients with OCD or BDD? And in general, we can say that about 2/3 of people will benefit compared to about 10% of placebo. But of course, that doesn't tell you whether you will benefit. And that is always a problem. It's just on average, 2/3 of people who receive a particular drug will benefit compared to about 10% of the placebo. In general, it's as effective as CBT in controlled trials, and that's why, well, partly why it's combined with CBT in severe cases. And the other thing to say is that it's effective even in the absence of depression. You don't have to be depressed in order to take these medications for OCD and BDD. And so there is a whole range of different drugs now available. Citalopram and escitalopram are closely related. I've given you there the UK trade name and the USA trade name. The usual starting dose, that can be a lower starting dose if you're particularly sensitive to side effects, but the key thing is usually trying to increase up to the maximum tolerated dose, because generally higher doses do better in OCD and BDD. Although clomipramine is on that table, it's not strictly an SSRI, it's what's called a potent serotonin reuptake inhibitor, and I'll talk about that separately. Paroxetine is not used very much these days. That's because it's got what's called a very short half-life and more difficult to come off. Again, fluvoxamine, perhaps not so popular, perhaps because some people used to start at a higher dose and then get more side effects, but it's still just as good as the others, really. Now, we talk about a trial of these medications in OCD and BDD as being 12 to 16 weeks. In other words, if you can only really conclude whether it's been helpful for you after that period of time. If they're not helping, then you'd be advised to switch to an alternative SSRI or clomipramine. If it's successful for you, then there may be a high rate of relapse when stopping. So that's why you'd normally be advised to then continue it for at least 1 or 2 years, when there's much, there's a less risk of relapsing. These drugs don't tell us anything about the cause of OCD and BDD. Perhaps people who have lower levels of anxiety are less likely to benefit, but there's no good evidence of predictors of who will and will not benefit from these drugs. What are the possible side effects of SSRIs? Well, the first one is nausea. About 25% of people taking an SSRI versus about 10% on the placebo may experience nausea. So the advice is usually to take them after food. If you experience nausea, you might temporarily halve the dose whilst your body gets used to it. Sometimes you might take an anti-nausea drug at the same time. Some SSRIs may be less likely to cause nausea, so your doctor might switch it to a different SSRI. In general, though, this symptom improves over time, and if you can persist with it for the first few weeks, then the nausea should subside. The other problematic one is diarrhea in about 15% of people taking SSRI compared to about 5% of placebo. The most important thing here is to keep yourself hydrated. And sometimes constipation, about 5% of people taking an SSRI. Again, make sure you drink plenty, take plenty of fruit and fibre or some sort of bulking agent. Headaches occur in about 20% of SSRIs compared to about 15% people taking a placebo. Again, make sure you're well hydrated with water, use painkillers. Again, these tend to generally improve. The symptom tends to improve over time. Excessive sweating can be a problem in about 10% of people taking an SSRI compared to about 5% on placebo. You could try to reduce the dose. It might be related to anxiety. Again, it tends to improve over time. Sometimes it can be improved with anti-glutamergic drugs such as benztropine to reduce the sweating. What about problems of dry mouth? About 10% of people with SSRIs will get a dry mouth compared to about 5% taking a placebo. This can be improved with sugarless gum, artificial saliva products, keeping yourself well hydrated, good dental hygiene. Again, this will tend to improve over time. Tremor occurs in about 10% of people taking SSRI versus about 3% of placebo. That could be improved sometimes by taking an additional beta blocker like propranolol. Emotional numbness. I couldn't really get any good details of the frequency of this. I don't think it's not a common one, but it's certainly well recognised. It may be part of the depression. Sometimes it can be helped by reducing the dose. But it is a problem with these medications in some people. What about sexual problems? Well, men may experience delayed ejaculation, women may experience difficulties in achieving an orgasm. It may be possible to get around it by lowering or missing the dose on that particular day. Some of the SSRIs may be better than others, and so sometimes it's easier to switch to a different SSRI. Some people have found that Viagra or Viagra-like drugs can be helpful. Sometimes you can add a different type of antidepressant like trazodone, which can be helpful to overcome this problem. There may be other factors like depression, OCD or relationship problems that combine to make this a problem. But it is a recognised problem. Sometimes sedation or insomnia can be a problem in SSRIs. About 15% of people taking SSRIs get sedation, about 5% experience insomnia. It's usually taken in the morning, so it might be helpful for trying to alter the time you take it, perhaps even take it in the evening. Again, you may need to switch to a different SSRI. It's important to stick to good sleep hygiene and making sure you get up at a routine time. Sometimes a sedative drug, promethazine, might be helpful in the short term or used as required, but it's obviously not a good idea to get into a routine with such drugs. What about loss of appetite? About 5%, 10% of people experience loss of appetite taking an SSRI. Sometimes you can get around this by reducing the dose. Again, it's complicated by the effect of depression, where you may get loss of appetite. It should improve over time. What about nervousness or agitation? Again, a minority of people may experience nervousness. It's best then to reduce the dose or perhaps switch to a different SSRI. Sometimes you can use an additional drug to overcome it. It should, again, improve over time. Serotonergic syndrome. This would be very rare in OCD, even at the highest doses. I don't think I've ever seen it in my career. So it's manifested by tremor, agitation, restlessness, diarrhea, increased blood pressure, heart rate, temperature, bowel sounds and sweating. These need urgent medical attention. You should go to casualty. But as I said, it would be extremely rare in OCD. But it's a potential side effect. It's where you're getting too much stimulation of the serotonin system. You're more likely to get drowsiness and fatigue, and that's why you take it at night, or perhaps spread it, the dose during the day. But most people are usually taking it at night, and some people that can be helpful where they need help to get to sleep. Very rare urinary problems, more likely in the elderly, where you get sort of urinary retention or difficulty passing urine, where you'd have to discontinue the drug. Heart problems, well, again, if you're more elderly, you've got pre-existing heart disease, you might need to do a ECG. Things to be looking out for is an irregular heartbeat or prolonged QTc interval. As I said, it's really more of a theoretical problem, and it's only really in someone with heart disease that it's a problem. So, of SSRIs and clomipramine, the question is, can you drink alcohol with SSRIs? Well, it's best to drink safely, of course. A minority, small number of people can become a bit more sedated or aggressive with the SSRIs or clomipramine with alcohol. So I'd always suggest that you would test it out at home beforehand, but it might make you a bit more sedated, probably. What about children and adolescents with OCD and BDD? We know that SSRIs are as effective as adults in OCD. Long-term safety is not known, but we do know that, of course, the long-term effects of untreated OCD are known, and so you do have to weigh up those two. It's the same side effects as adults, but perhaps children and adolescents can become a bit more excitable, irritable, and that's why it needs to be monitored more closely. Children usually start at a slightly lower dose. The ones that are usually chosen are sertraline or fluoxetine, as that's the ones which are known most about. It would need to be initiated by a child and adolescent psychiatrist. What about combining SSRIs and CBT? Well, it's usually recommended in severe OCD or BDD. We think that the expert opinion is that CBT can reduce the risk of relapse. Sometimes it gets a little problematic. Imagine, for example, if the medication is too successful, the CBT is difficult to do. If, however, the CBT is more successful, we don't actually know the impact of stopping the medication and when to stop. So usually we prefer to do one treatment at a time, but as I said, when it's significantly severe OCD, you really do perhaps want to combine it. The problem is, if you do relapse, you may need a higher dose than required beforehand, or it may take longer to respond. So it is problematic. What about when you do stop them? It's uncommon to get withdrawal symptoms. It's quite safe to manage it by a gradual reduction, particularly when you're at a higher dose. Withdrawal symptoms come on within the first few days, whereas relapses are more likely to occur within about 3, 4 or more weeks. That's the way to usually differentiate between the two. Sometimes you might use what's called megadoses. You remember that certainly the normal highest dose used in OCD and BDD is 200 milligrams. There's a bit of evidence that very high doses can be used in very severe treatment refractory OCD, which hasn't responded to anything else. So it's usually used after other trials and medications, and CBT has not been helpful. You do have to have some precautions here. You'd need to have an ECG done, checked at regular intervals, sometimes a blood level. If it's being, your GP, I'm afraid, will be unhappy to actually prescribe this because it's going above the normal recommended levels, and you just monitor the side effects. So it would need to at least be initiated by a consultant, and perhaps still continue to be prescribed by a consultant, because I'm saying that some GPs would be unhappy about prescribing at very high doses. What about pharmacogenetics? This is where you have a mouth swab for DNA analysis, and you then get a detailed report on the metabolism of different medications. So I can say there's only very limited evidence for this in using SSRIs for OCD and BDD. It's perhaps used if you were sensitive to one or more SSRIs, and it's perhaps a bit better than trial and error. It's expensive because it can only be used privately. It costs you about £700. You then get a sort of report back like this that tells you, well, for this person, perhaps they're get more side effects, less likely to respond to fluvoxamine paroxetine, and the one there that might be more helpful to use is sertraline, or possibly their clomipramine. But as I said, it's limited benefit I've found. Some people has been helpful, where it can highlight one or two particular SSRIs that suggest that it's going to be better, but the evidence has got to be collected. What about anti-psychotics for OCD? This is not used in BDD, and they're not because patients are psychotic, and it's just that they're usually used in higher doses for psychosis, and can be used to treat schizophrenia and mania. So here they're just being used to augment or enhance the effect of the SSRI, and we can best describe them as being dopamine blockers. And as I said, they're used when you've had at least 2 trials of SSRIs or clomipramine and there's been a very poor response. On average, adding an antipsychotic is a weak treatment compared to SSRIs or CBT, but some people do benefit. And a trial would be for 4 weeks, and its low doses are used compared to those when it's used for an antipsychotic. So normally the choices of risperidone, 0.5 to 1 milligram, or aripiprazole, between about 5 or even 10 milligrams. As I said, when these are used in psychosis, the dose of risperidone may be something like 6 milligrams, 4 to 6 milligrams, or aripiprazole may go up to 30 milligrams. So you can see it's much lower doses. And not all antipsychotics are probably necessarily helpful. We just don't know. You can see here in this what's called a meta-analysis that was aripiprazole and risperidone that was probably a bit better. But as I said, on average, if you take all the antipsychotic trials, it's a weak treatment. It's on average about a Y-box change of 2 compared to SSRIs and CBT, where you get an average about 10 or 12. But the problem being is we don't know which particular individuals will respond. And there are some people, maybe about 1 in 5, who get a significant benefit from adding this particular drug. What about antipsychotic possible side effects? Well, in low doses, when it's used in OCD, probably maybe one of tiredness, and that's why it may be taken at night. It's only in the higher doses used in treating psychosis, where you're more likely to get things like weight gain, attacks, potentially stiffness or hormonal changes, or even slurred speech. So it's not usually an issue in the lower doses in OCD. 1 or 2 other drugs which have been used in OCD. These are what we call glutamergic drugs that stimulate the glutamergic receptors. These are again used with your SSRI when you've not had an optimum response. These include drugs like lamotrigine, memantine and pregabalin. And in general, again, a modest anti-benefit. This would need to be recommended and monitored probably by a psychiatrist. Very last, I'm going to briefly mention transcranial magnetic stimulation. This is something that's certainly been used in depression, and there's some evidence in OCD. NICE recommended that we needed more evidence before it was recommended more widely. So at the moment in the UK, it's only really used privately. You have daily sessions, 5 days a week for 2 or 3 weeks for a trial. Some people say that you can tell, though, if you're going to respond after 1 week. It's a different sort of treatment compared to depression, where you have a helmet or figure-of-8 coil that's recommended for the trial so far. Some people may experience a slight headache or local discomfort, but it's just something like a magnetic thing that's applied over your head by the technician. So there is more information you can get from our books on overcoming OCD and overcoming body image problems. We've got a whole chapter in there on using medication in each of those 2 books, and it goes into more detail than what I've been talking about today. So I hope that's been helpful for you, and that's all, folks.